Coronary Pseudoaneurysm Stent Thrombosis. Dr. Urwah Imtiaz. Urwah Imtiaz.
Assalamu alaikum. My name is Dr. Urwah Imtiaz from Cardiac Center, Bahawalpur. So my case is a 40 years old male that was admitted with non-ST elevation MI. He was a smoker and hypertensive. His ECG showed deep T-wave inversions in chest leads, and the echocardiogram showed anterior wall hypokinesia with ejection fraction of 42%. His pre-cath lab reports were within normal limits. So on the basis of these findings, we plan to perform coronary angiogram of the patient. So the coronary angiogram showed a proximal LED disease, that was severe disease in the proximal LED. Further views showed that there is a moderate distal disease of the left main stem and mild ostial disease of the circ. So we plan to perform PCI of the proximal LED disease. So a stent of size 2.75 into 28 millimeter was deployed distally in the proximal LED. Another stent of size 3 into 24 millimeter was deployed in the proximal LED, overlapping the previously placed drug-eluting stent. Post-dilatation was done with 3.25 into 12 millimeter balloon at 22 to 24 atmospheric pressure. This was the final view. Final check injection showed TIMI3 flow in the LED, and there at this stage, we were seeing that there is no extravasation of the contrast dye or stent seemed to be of appropriate size. So what actually happened? That patient again presented with acute anterior wall MI 5 weeks after the index procedure, and we were considering that it is possibly due to stent thrombosis. So patient was thrombolized with streptokinase, and rescue PCI was planned and coronary angiogram was done in the next morning. This was the ECG of the patient, which showed acute ST elevation MI. So what actually happened the next morning, when we performed the angiogram with plan to perform rescue PCI, there was a huge pseudoaneurysm that was extending from the overlapping part of the previously placed drug-eluting stents, and it was also having a Ellis type 3 perforation that was cavity spilling. So what next? The treatment options we had that were to perform surgery or to deploy covered stents. So we decided to implant covered stents. Immediately, the echocardiogram was done whether this perforation is in the pericardial space, but we found that there is no fluid in the pericardial cavity, and the patient was hemodynamically stable. So we decided to deploy cover stents. PK Peppers of size 3 into 15 millimeter was deployed distally, and another stent of size 3.5 into 15 millimeter was deployed proximally, overlapping the previously placed cover stent. We decided, provisionally we decided to deploy 2 cover stents because of the logistic availability. We had only available we have only the availability of the cover stents of 15 millimeter only. So regarding the base of the pseudoaneurysm, that was more, so we decided to deploy 2 cover stents and overlapping them. This was the final view after the deployment of the cover stents, that the pseudoaneurysm as well as the perforation was sealed. And patient was stable and discharged home safely. Left main stem assessment and surveillance angiogram is in plan. This was the echocardiogram which showed that there was no hemopericardium. So the learning points were pseudoaneurysm after drug-eluting stents are well-recognized rare complications after death, and ranging from 0.3 to more than 1% is the incidence. The causes are multifactorial, but in our case, the cause of pseudoaneurysm was possibility of vessel trauma that was due to the overstretching of the vessel during the index procedure and contained perforation that extended further to form a pseudoaneurysm. And cover stents were life-saving in this procedure. Thank you so much.
Any comments?
I think as far as the first stent was concerned, there was some haziness in the middle of the stent, and
Can
might be
you
there
show
is
the first views?
fracture of the stent starts in the beginning. That has caused all these things. Second, I don't think that there is formation of pseudoaneurysms in the so earlier phase. I think there is, as far as the hemodynamics is concerned, there might be a fistulous formation, or there is a frank perforation which is opening into the cavity that has caused because of this there is no hemodynamic compromise.
So I think it's a wonderful case, to be honest, to start with. But there are a couple of observations. I think we can have a lot of discussion on this case. And the first thing is, I totally agree, there was some haziness post-stenting, and the other thing was maybe there was strut fracture, and there is a complete classification for that. You know, maybe there was a break in the struts, or it could be slight subluxation. I was not sure from that particular view. But the other thing is, maybe initially there was some oozing within the septum, as there was something that opened up, and it was well contained. Maybe there was a fistulous communication afterwards. It's not sure, but it seems to be draining in another chamber, most likely pulmonary artery. So I think all these questions would have been answered if we had intravascular imaging done. Maybe that would have answered all the questions, but still I think...
Or a CT
Yes,
angiogram.
Yes, yes.
As there
CT
wasn't
angiogram.
any effusion there, and patient wasn't really in a situation where you need something urgently, you could have done CT angio to see exactly where the communication is, and you may have saved your one covered stent if you know exactly the location of this abnormality. Second, apparently I was thinking there was severe lesion in the mid-LAD, and proximal LAD had a plaque, but it was non-flow limiting, and you may have some landing zone in between that region of proximal LAD to that here severe lesion. So why do you haven't thought of just putting one stent there and leaving your proximal altogether on medical treatment? Because actually it happens at the overlapped site, where your stents were overlapped and then you over-inflated that region. And that lead to injury of that. So I think that would have been saved this patient from these all complications. And subsequently CT angio would have given you an exact idea what's happening, and then IV imaging to decide what need to be done. Any other comments?
One comment. After putting a cover stent, it's better to have a post-stent dilatation as well.
Yeah.
Because sometimes leak is coming out from the sideway and you can't match it to the vessel wall. The deployment is not proper, so you can't seal it properly. So better to have NC dilatation. And if it is not an affordability issue, you can put a DES after having a cover stent.
It's such an interesting thing, something on the angiogram, you take a look at it first up, you think it's LS4, but then you see how could LS4 be stable for such a long time. So again, I think that's something which pushed them to think in terms of having a pseudoaneurysm, but I think CT and imaging would have made it easier for all of us to understand.
I think there was no need for echo even, because the patient was hemodynamically stable. With that much leak, I don't think the patient will be that stable. May not reach the cath lab even. So this was sure that this was not into the pericardial space. The other thing was whether this was aortic or into the LV outflow or right outflow. So this is crisscross. If it is going this way, it is LV outflow. If going this way, this is RV.
Very right. I think it had to be
I
the
have one
septum to
comment
save
as well,
him
please.
for such a long time. So totally agree.
Yeah, I was wondering, why did you put 2 stents initially? The length of that stent, one of them was 28 millimeters. So you could have used a longer stent, a single longer stent for that initial angioplasty.
Sir, initially at that time, we were suspecting that a long stent or maximum stent size available in our cath lab is 38 millimeter. So we were suspecting that 38 millimeter would miss the lesion. So we put 2 stents and overlapping them.
And this was 2.5.
2.75 28 millimeter is the distal stent, and 3 into 24 millimeter is the proximal one,
Okay,
with
yes.
the overlap of almost 3 to
Rehan.
4 millimeter.
Dr. Rehan want to say something.
I have 2 questions. The first one is, excuse me, hey.
Yes, sir.
I'm Dr. Rehan Umar. I have 2 questions. The first one is that you mentioned that the patient had stent thrombosis, right? So why wasn't the patient taken to the cath lab in the first instance rather than giving him SK? And number 2, if you look at the stents, the initial stent that you put in, both of the stents were opening into the plaque. So was that justified?
Sir, for answering the first question, in our center, there is the patient landed in the emergency at the night time, and we have our cath labs working or functional up till 5 p.m. or more. So at that time, immediately patient was not shifted to the cath lab. If we had the logistics available at the night, we would surely shift the patient at that time and perform the coronary angiogram at that time. Sir, second question, please.
The stents, they landed in the plaque. So once you stented the segment, the stenotic segment, the second stent landed in the plaque. And that's the reason why, if you look at the final angiogram, you can see that there is post-stent stenosis, which should be hemodynamically significant. I don't know whether you did the IVUS or not, but it seems to be significant.
Sir, at that time we had no IVUS available. IVUS catheter was not available, so sure we should do this.
Okay, thank you very much.
Thank you.
And let's end the session. Thank you all for attending the session. Thank you to the experts and presenters as well.